I'm going to share our experience with OCT-A in macular surgery. We started using spectralis, so two-dimensional OCT to look at patients with macular packer and see if we could use all the information that we obtained from the spectralis to reproduce a map of the macular packer that could help us during surgery. And this was one of these cases, and we were then able to manually reconstruct a map that shows us the shape and face of the macular packer, and to reproduce this map on a red-free photograph so that we could see the vessels for a reference. And then we brought this map to the operating room, and we marked on the map the place where we thought was easier to start the peeling. And now you can see in surgery, guided by the preoperative OCT, we start the peeling of the epiretinal membrane in that point that we have marked preoperatively. And in my opinion, that makes, in many cases, easier, even without the use of dyes, to complete the peeling of the ERM without much traumatism to the retina. We then try to use the OCT-A. The advantage of the OCT-A is that you have an en-face image of the retina and of the macular packer, and you also see the vessels of the retina. So on one image, you immediately have the reference point of the area where you would like to start your peeling, as you can see in this case, and in this other case where there are different areas where the epiretinal membrane is far from the retina, and you have the vessels on the en-face image to show you where this area is, and we can use these images as a guide for our surgery. We also looked with the OCT-A to a series of 25 patients that had macular packer surgery, and we examined this patient preoperatively and after surgery, and to see if there was changes in the vessel density in the superficial and deep plexus between before and after surgery. The vessel density was measured in the foveal, parafoveal, and total central area. And this is one of such cases. You can see that before surgery, in a macular packer case, there is a total alteration of the normal vasculature in the macula. You cannot see the foveal vascular zone, and the vessels, the capillary are very tortuous, and this is the superficial vascular plexus in the macula with the OCT-A. After surgery, there is a progressive restoration of the normal macular vascular anatomy. And this is the deep vascular plexus, and again you can see that after surgery for macular packer there is a progressive restoration of the normal anatomy, and you can see at 3 months again a foveal avascular zone which was not present before the surgery. So we looked at our data, and really what was statistically significant was a change in the vessel density in the foveal area in the superficial and the deep plexus. After surgery, we see a restoration of the normal vascular anatomy, which is statistically significant. In conclusion, the use of OCT-A may be helpful in planning for surgery. It may be also helpful in evaluating the vascular changes before and after surgery. And we are now trying to evaluate if we can use the OCT-A as a biological marker to tell us how much function we can restore, and when would it better to start surgery immediately before the foveal vascular zone disappears because of the distortion caused by the macular packet. Thank you.
Antonio, did you mean that the vessel density increased after surgery?
In the fovea, it decreases because you don't have a foveal avascular zone usually, so the vessels are all there is no avascular zone in the fovea, so the vessel density is higher in the central fovea in the macular packet before surgery, and then it tends to decrease after surgery.
Thank you.
Any questions from the floor?
Yeah, thank you very much. Ahmad Aboud from Cleveland Clinic, Abu Dhabi. Are you routinely peeling ILM after removing the epiretinal membrane? And are you able to tell if that peeling made a difference in the, do you have some patients who did have ILM peeling and those who didn't? Just interested in your input about that.
Yeah. I used to, I don't have, exact data, but my, surgical impression is that you don't need to peel the ILM in every single case of macular packet. I used to peel the ILM every case, and then we noticed some damage to the retinal nerve fiber layer, and we published that. And so now I'm more careful, especially if I have a patient with glaucoma that already has a cap disc and a thin retinal nerve fiber layer, especially in these cases, I prefer not to peel the ILM.
Antonio, I have a question for you. I know that there are multiple factors involved in the epimacular membrane peeling. For example, the timing of the surgery and the number of the dye injections. So you may have to inject the dye 1 or 2 times. And also the direction of peeling. What are the effects of these factors on your results? Briefly.
Yeah, it's difficult to say. I'm sure that we all have the same experience, and we don't know exactly, if using the dye 1, 2, 3 times makes a difference, doesn't make a difference. So it's a difficult question. Personally, I try to use the dye just once, so I prefer to peel the epiretinal membrane without dye, and then I inject the dye after if I want to peel the ILM. So I try to use the dye just once. I try to peel very tangential to the retina, not to peel up, and that's all my suggestions.
Okay, thank you.